I want to hear some enthusiastic yeses. Come on, you guys.
We're
Continuum
ready,
of care.
Karen.
There we
Let's
go.
go.
Yeah,
Yay!
let's
Ready.
go.
Hey,
We're
that's what I want to
ready.
hear. We have a lot to celebrate and talk about and share. Welcome to the September 17th, 2025 Continuum of Care meeting. Let's go ahead and move to the next slide. Everybody, so I already mentioned to make sure that you do, if you are a voting member, to click to for roll call. I always love to celebrate the expansion of the continuum of care. We want a very diverse, inclusive, robust Riverside County Continuum of Care. And so I'm excited to announce some new members. We got 4 this month. And if you are in the house after I say the 4 new members, please let us know. You can say hello. Restoration Transitional Housing Program. Anybody here from that organization? We also have Through It All Community Services. Anybody?
Yes, nice to meet you all. Pleasure to be here. I love the energy. Look forward to
Thank you.
collaborating.
Wonderful. Welcome. How about the Renee Williams organization? Anybody? Okay. Oh, and I love the name Next Level Living Resident. Anybody here from Next Level Living Residents?
Yes, that's me, Karen. Patrice Kinsey. This is my second meeting, so I'm excited. And to
Nice.
be
Welcome.
official, maybe after my third meeting.
We love having you. Thank you so much. Okay, we have 2 new voting members. And just to recap for any new members, you can become a voting member once you complete your application as a new member, and then you complete 3 consecutive meetings. We have first My Baby Way Foundation. Do we have anybody here from that organization?
Hi, everyone. I'm Soraya with My Baby My Way Foundation.
Thank you, My Baby My Way. Thank you. I appreciate the correction. Welcome. We love having you. How about Jewish Family Services of the Desert?
Yes, good afternoon, everyone. This is Craig Johnson, and pleasure to be a new voting member. Really appreciate the
Great.
opportunity.
Yeah, welcome. So, I had asked our team to list the numbers so that you could see them on the slide. And next month, we're going to have a grand total because the general members are separate from the voting members. So we have a total of 160 organizations that are participating in the Riverside County Continuum of Care. So we can raise the roof, everybody. And continue to make sure that you invite people to be a part. We need all different stakeholders at all level, public and private, to be able to prevent and end homelessness in Riverside County. So happy time for us to celebrate new organizations. So let's go to the next slide. Okay. You may, if you were at the last meeting, you heard me say that if we do receive any written comments, the Continuum of Care staff will put them in the Google Drive. So we did not receive any written comments, therefore there are none in the Google Drive, which you have access to in the meeting invitation. Do we have anybody that would like to make a public comment to the Continuum of Care? If you'd like to do that, please raise your hand. You have 3 minutes to make a comment. You can use the raise your hand function if you would like to speak. Anybody? Oh, you guys are so quiet today. Going once, going twice. Okay, no public comments. We'll move on to the next agenda item. Okay, I wanted to take a quick moment to talk about the Continuum of Care survey and the annual meeting. So shout out to Zuli for getting this slide organized. You all received an email with a link to the survey, but it's so quick and easy. We really, really, really want your feedback. This meeting is for you. It is for the people that you're serving, and we are better together. And the purpose of this meeting every month is not for the sake of meeting. We want to be strategic. We want to be action oriented. We want to be compassionate. We want to get stuff done to help people. So we like to hear what you have to say about the meetings, things that we should keep doing, things that we should add, things that we should change. You can use your cell phone right there on the QR code and literally take just a second to complete the survey, because sometimes emails get buried. We're all so busy. So if you haven't taken it, please, pretty please, take the survey. It's super duper easy. Also, we're going to be sending this out by email. Oh, Zuli, can you link the survey also in the chat for them? Someone is requesting that. There's the invitation that we'll be sending out by email for those of you that participated in the in-person meeting last year. The chair of the Continuum of Care is hosting, so the city of Corona will host it at the Circle City Center. It's a big, huge community room, so we have room for lots of RSVPs. You can RSVP there. It looks like Zuli linked the RSVP already. So, and then we'll send out some reminders. We will, the city of Corona will be hosting lunch. It's more like an early dinner because the meeting is from 3 to 5. And Tanya and her amazing team will have games and recognitions, and really it's just going to be a beautiful time to break bread together, see each other in person, give each other hugs and high fives, and just celebrate the work that we do to be refreshed and renewed. So we would love it if you can come. We will, for those that might have transportation challenges or just have too much going on at the same time, we will allow for remote options, as we have in the past. But we hope that you will take the opportunity to come and see each other in person. There's just something to be said about gathering together in person. So just want to give those few plugs, and hope that you guys will come and participate in the survey. So thank you. Let's go ahead and move on. Does anybody have any questions before we move on? Okay. Let's go ahead and go to the next slide, Miss Uli. All right, coordinated entry lead update. Miss Lucy, we moved you up. You have the floor.
Hi, good afternoon. Thank you. Can everyone hear me okay? Yes, okay. Thank you. So I'm going to be giving some data from the month of August from CES. Slide. So regarding Home Connect calls, there were about 832 phone calls in the month of August. Of those calls, 716 of them resulted in diversions of providing resources to prevent homelessness or eviction or any other supportive services that a member that called may be in need of. And 262 of the callers were screened and linked to the coordinated entry system. Of those that were screened, 78 were families, 4 identified as veterans, 20 were aged 55 plus, and 5 were of TAY age. With the remaining phone calls either being out of county callers or those that were just calling in for general inquiries, such as like their caseworker information or what have you. Next slide. And the end of August also accounted for about 991 members on the community queue. When looking at the cities with the highest numbers of those on the queue, Riverside did see an increase of over 30 members, as did Indio of about 13, and Palm Springs also saw a little uptick of 8 more members. So while overall there was a general increase from one month to another, we want to see this as a positive note that those that are in need are being connected and being reached out to. So CES did refer about 60 households last month to housing opportunities. 32 were connected to permanent supportive housing and 28 to rapid rehousing opportunities. And of those referrals that were sent out in the month of August, 20 were senior age, 9 were for TAY, 1 was for someone that identified as fleeing domestic violence, and 1 identified as a veteran. Next slide. CS will be holding referral status check-ins to touch base with navigators and agencies that requested vacancy referrals to ensure that Home Connect referrals are not left in limbo and are closed out, to ensure whether it's a successful match or even if alternative housing has been found for the member that wasn't necessarily through CES. And that way there's not referrals that are left open for long periods of time, and to ensure that clients are not left with a lapse in service. We've also identified patterns of error in data and will be working with agencies to train in running data reports and training for to ensure that these data errors are done less frequently and resolved in a timely manner. HMIS is also partnering with the Coordinated Entry System to provide trainings during CES partnership meetings, and CES is going to be providing trainings during the HMIS office hours, just to make ourselves a little more accessible. Next slide. We're requesting any agencies to come in and present if you guys have some services or resources that you would like to expand out to more crowds. I do hold those monthly resource meetings for CES partnership. And we are looking for the remaining, I believe it's the last 2 months of the year. So if you know any resources that are mid-county specific, just since involved, or are offering rental assistance, I know that's a big one at the moment, please reach out to me or put it in the chat and I will reach out to you to get you on calendar. Next slide. So we're always looking for feedback. Anything you guys want to see more of during partnership and CES in general, please reach out to myself or Home Connect. Other than that, that is all I have for you all today.
Anybody have any questions or comments for Miss Lucy? Lucy, to you and the rest of the team, thank you so much for the important work that you all do. We couldn't do what we do without coordinated entry systems, so thank you and know that we appreciate you guys.
Thank you so
That's
much.
good. We move to the next agenda item. Okay, leadership spotlight. So each month, the privilege of spotlighting leaders and organizations in our continuum of care. And often Tanya and I collaborate on these, and there's a big, huge focus for transitional age youth, and we've had the privilege of having YHDP resources, and you think about this system that we've been trying to build to better serve youth. Tanya had the good suggestion that we showcase Silence Aloud. And so we have 2 speakers today. I'm going to tell you a little bit about them. So we have Melissa, is it Delzio? And she's the clinical director for Silence Aloud, their Bridge Wellness Center and Searchlight Center for Healing. She's a licensed marriage and family therapist, and she's been dedicated to supporting youth and families since 1998. Her work spans leadership roles in LA County, Moreno Valley Youth Service agencies, where she has championed care, compassion, and access to vital resources for foster youth, undocumented and unaccompanied youth, and individuals experiencing homelessness. She brings deep expertise and heartfelt commitment to every space, and inspiring hope and resilience in the communities that she serves. And then for Amber Gonzalez, a little bit about her. She's the program manager of Silence Aloud with the Bridge Wellness Center with over 10 years of experience in social services. She is committed to supporting youth impacted by trauma and systemic neglect. Amber leads with empathy and a commitment to equity, driving programs that offer healing, housing, and supportive services across Riverside County. Ladies, we are excited to have you and feature Silence Aloud in the Leadership Spotlight. The floor is yours.
Hi, good afternoon. Can you guys hear me okay?
Yes.
Hi, nice to meet everyone. Thank you so much for providing us with this opportunity to present our agency and some of the services that we are able to luckily provide for our Riverside County residents, along with being here in Moreno Valley. Melissa, I believe she's on. I'll just have her introduce herself.
Good afternoon, everyone. I'm so glad to be here, and thank you for the great introduction. Amber will be going through the slides, and then we'll answer any questions that you have after our presentation.
Thank you for that. So we are located in Moreno Valley, Silence Allowed, and we are with the Bridge Wellness Center. A little bit about our mission, providing housing, foster care, advocacy, and support in all forms necessary for children, adolescents, and young adults. For victims of abuse, physical, emotional, and sexual abuse. We do have a few innovative programs, and that consists of the Bridge Wellness Center is a safe space for youth ages 25 and under. We do have some technology and computer lab available, music recording studio. We have a Artivism Youth Wellness Project and other special events. We also have we are considered a homeless youth drop-in center for the ages of 24 and under, supportive services and referrals. We provide peer support, housing navigation, employment help, and other basic needs. We also have our STRTP, which is a 24-hour residential treatment center, mental health, and we also do probation support 24 hours from ages 13 to 21. And we also partnered with probation with our Rise Up Youth Empowerment Program, and that is for anyone under the age of 25. For justice involved youth, we provide mental health, legal resources, peer support, legal assistance, and workforce skills. Our vision is a place of access, possibility, and support for our youth and young adults. What is the Bridge? A true one-stop shop for our youth under 25 years old. We provide support for housing, health, education, employment, and much more. And these are a few videos that I wanted to be able to present to you. We can go from left to right if that's okay.
Zika.
If you can transform your beliefs, you can change yourself to be whatever you want. And so that's what we're talking about. But a lot of times we stay stuck because we're attached to that old person. That old person wants to live. That old ego wants to stay the same. Don't want to change, right? It's familiar. And there's a lot of reasons for that. I don't have time to tell you, but I want you to understand that you can create yourself over again. The most successful people in the world have goals. Right? And so you can break those goals down, long-term, mid-range, short-term, all the way to daily activity, right? The Proverbs said, where there's no vision, people perish. They died. They cast off all restraint, right? And so we got to understand having a vision is important. Albert Einstein said imagination is everything. The whole universe is made of patterns. And if you can learn how to control the patterns, you can control the outcome of your life. Right? And so that's all it is taking those old bad habits and switching them out for some new habits.
Today, it isn't just about opening doors. It's about opening access, opening possibilities, and opening hearts to what's possible when a community comes together. At Silence Aloud, we believe that every young person deserves a place to go. When they don't know where to turn, a space that's safe, supportive, and stocked with solutions, not just pamphlets. and promises. It doesn't take many. It just takes a few.
And that just gives you a little insight of what our facilities are able to provide for the community. The first video was the open door or open night that we presented here in our location. A few other clips in there involve some of our open mic nights, our artivism program, some of our workshops that we are able to partner with other community partnerships to present workshops for our clients, and they're also open for the community for purposes of having that one-stop open door aspect of it, so we can try to bring in some more of those clients in and have them be a part of our agency and provide some of those services there.
If you can
Today,
We have the YHDP program, and so we are an official drop-in center and a navigation hub. Some of the program eligibility requirements are age of 24 and under, currently risk or at risk of homelessness within 14 days for the residents in Riverside County. Some of our supportive services under the YHDP program is housing focused, case management. We assist with vital document support, basic needs, mental health, youth navigators, peer support and life skills, and also access to CES via Home Connect. And our YEP program is our Rise Up Youth Empowerment Program, which is through the Riverside County Department of Probation to provide supportive community services along with other workshops like drug and alcohol awareness, victim awareness. And we can send over our calendar that we have available with our routine scheduled time slots for any of the participants to be able to attend. Rise Up services include housing referrals, basic needs, peer support, life skills, system navigation, legal support, mental health, and may fulfill court requirements as well. And the eligibility for that is 25 years and younger, current or previous justice system involvement, and at-risk youth justice system. And then how to get help, we do have that QR code there. It takes them, our clients or the community, directly to our form to submit an inquiry. They can do it through the QR code, the referral through CES or walk-in center, and we can connect them with the supportive services and a case manager. And our office hours are extended, so they're from 10 to 8, and we are located in Moreno Valley off Ellsworth Street. Our phone number is there, our email address, and our website. And these are some of the ongoing activities that we provide for the youth. We have open mic night every third Friday from 7:30 to 10:30, and that's monthly. We also have Mondays open session for podcast vlog space from 12 to 5. Tuesdays and Thursdays, we have a recording studio available from 12 p.m. to 5, and Wednesdays after school walk-ins for our tech lab from 12 to 5. And we also have Wednesdays walk-in therapy sessions from 10 to 5, and also group life skill workshops from 6 to 7. And the nonprofit, we're trying to just build together with our partnership and our community outreach with mentorship, financial literacy. We provide life skills, supportive services, vocational training, entrepreneurship, workshops, internships, and arts and media. And this is our direct contact. So if you guys want to go ahead and partner up with us or use us as a resource for any of your clients that you're currently serving, please feel free to take a screenshot and contact us directly through those email addresses there, or give us a phone call, or just chime in, walk on by and visit our center. We'd appreciate you guys for letting us utilize this time for to express our interest in assisting our community. Thank you.
Thank you so much. Oh, so any other, are there other comments from you guys, or do we want to open it up?
Yeah, Zillia, I just want to add in that we do have clinicians on site here that are trained in evidence-based practice, such as cognitive behavioral therapy, EMDR. We host a variety of different support groups and life skill groups, psychoeducation. So anger management, seeking safety for substance use. We have life skills, educational skill building, as well as like trauma focused groups. So I just wanted to put that out there.
Awesome. Before we open it up, I hope that you all, as different organizations and participants in the continuum of care, if there are youth that are coming to mind that you guys have been serving and you feel that there's an opportunity for collaboration, I hope that you will consider collaborating. Tanya, I know you have your hand up, and I know you also had a vision to see if we could do cross-pollination and integration. So besides, maybe you could talk about that a little bit too, because you do have the benefit of seeing the whole YHDP system and all the agencies, but this goes beyond YHDP agencies, right? We want to reach everybody in the youth community.
Yes, thank you, Karen. And that definitely ties into what I wanted to share. But first, wanting to compliment Silence Aloud. I know their director, Kanisha, really wanted to be here. And so I wanted to recognize the organization who has worked so closely as part of our youth homelessness demonstration program, or YHDP federal grant that we received with all of you, many of you at the Continuum of Care, but especially our Youth Action Board, who we should probably look at bringing into a next future Continuum of Care meeting to talk about the work that they're doing. This is a group of young adults, many with lived experience, who are between the ages of 18 to 24 and are an advocacy, but also planning body, and have helped us design a lot of our programs, and specifically this center. I think what I really wanted to emphasize to the Continuum of Care is that the idea of this program, of this model, is really intentional, and in our attempt to really continue centralizing how we're coordinating services across our really big county. And Amy Primrose, who heads our YHTP program, was in Marietta, as an example, 2 days, speaking with the 4 different cities and the boots on the ground to highlight the work that is being done, but also to encourage the street outreach teams and the housing navigators and case managers to work closely with Silence Aloud, and to make sure that as they identify youth who are on the streets or who are being referred through our school districts and even our colleges, and sometimes even our hospitals, right, that we're plugging them into this center that really serves as a hub and can help facilitate all the linkages that young adults need. So my hope is that again, this will become a central part of your operation, of your nonprofit's operation, so that if you come across a transitional age youth, 18 to 24, that you can call Silence Aloud and say, hey, help me with this. What's the next step? How do we get them plugged into housing? See this program as an extension of the work that you're doing, as a partner, formal partner that you can call to support you. So I just feel really proud, and we want to make sure that we're connecting youth and filling this space, which you have seen depicted in the video, was created with young adults in mind. It is a very inviting space, and there's a lot of really cool tools that are available to fast track youth to care. So thank you.
And I'm wondering if we could talk about, I hope I didn't miss this, but if we have organizations, because we have a big county, If we had organizations that were interested in getting their youth plugged in, maybe Melissa and Amber could talk about creative ways regarding transportation and how you effect that type of collaboration.
Yeah, I could talk a little bit about that. We do provide transportation vouchers, Uber vouchers, bus passes. However, we're not just restricted to providing that for them directly. We do have case managers that do travel to the client, meet them where they're at. So anywhere within the Riverside County, they're definitely able to meet those needs and meet them where they're at. If they have trouble with transportation or don't really understand how to go about the routes of the bus routes, things of that nature, they don't feel comfortable or safe doing so, we do have case managers that are available to meet them at other locations within Riverside County.
That's awesome. And even to get them to the drop-in center for participation in group activities and all the cool stuff you guys talked about, right?
Yes, yes.
Cool. Okay. Does anybody else have any other questions or comments? This is such amazing expansions of services to our region. This is super exciting. Anybody else? I would just say this, remember, sometimes silently slip into the larger population of the homeless community. So remember, because of the YHDP and other youth-focused resources, 18 to 24. So there could be additional enhanced resources that you all should be tapping into and thinking about for your clients. So I just wanted to put that plug out there. I think we all need to remember that because we all get so busy and just used to doing what we do with our own individual programs. So anything else, Miss Tanya, you want us to highlight before we move on to the next agenda item?
I think we got it all. Thank you.
Okay. All right. Thank you again, Amber, Melissa. Let's go ahead and move on to the next agenda item. Oh, did you have a question, Savannah?
I'm sorry. Yes, can we get the contact information for the Bridge Wellness Center? Silence allowed. Thank you.
Yeah, and just so everybody knows, those slides will be placed in the Google Drive, but maybe, Zuli, you can screenshot it and pop it into the chat so they have it in the meantime, because I know you will eventually be putting all the slides in the Google Drive, but so that you can have it now. Thank you for asking the question. Okay. If she gets that in there, then we'll go ahead and move on to the next agenda item. Okay, she's popped it in the chat for you guys. Any other questions, Savannah, or did we address it for you? See your
Yes,
hand
thank
is
you
still
so
okay,
much.
perfect. Miss Zuli, do we have a quorum? Okay, everybody, we
Yes,
have a
we do.
quorum, so we can take action. I believe we only have one action item today, consent calendar agenda 5.1, approval of the August 20th Continuum of Care meeting minutes. Do I have a recommendation to approve the minutes? Come on, you guys, don't be shy.
Move to approve. This is Chris, Path of Life.
Thank you, dear Chris. Do I have a second?
I second. This is Larissa from Hope.
Thank you, Larissa. Any objections or abstentions? Hearing none, the item passes. Let's go ahead and move on to the next agenda item. New business, Behavioral Health Services Act, BHSA. We have Diana Gutierrez from RUHS Admin Services Manager. So the floor is yours, Diana.
Awesome. Okay, you have my slides. Terrific. Thank you, everybody. Again, my name is Diana Gutierrez, and I am the Prevention and Early Intervention Manager here with RUHS Behavioral Health. And I'm also helping to lead the Behavioral Health Services Act transformation. I'm going to talk to you about that transformation today, and specifically the Behavioral Health Services Act. You might hear me call it BHSA or BISA for short. I'm going to share with you how BHSA funds some of our department programs, some of the new requirements of the Act, and how you can participate in giving feedback on the plan. Next slide. So to start, it might be easier to look at BHSA from a larger lens, so you can see the bigger picture. And this slide shows how the state sees BHSA integration in the larger system of care at the community level. Like when you're seeking any healthcare, you normally don't start with a specialist. BHT defines public behavioral health as specialty care, and this is important. This emphasis on public behavioral health as specialty care is at the center of all of the coming changes. This means that mental health prevention, mild and moderate mental health needs are designed to be met in the general healthcare system, like with your primary care doctor. Substance use prevention remains within the substance use treatment systems, but BHSA encourages greater integration and partnership in addressing behavioral health care needs across the continuum of care. The goal is to make care access and provision more efficient by eliminating the wasteful repetition that can come from silos of care. It's to have more comprehensive engagement in all care environments and to optimize the use of state and county resources. BHSA wants to make sure that BHSA funds are not used to pay for services that Medi-Cal or commercial payers are obligated to cover. Next slide. The Behavioral Health Services Act is an updated version of the Mental Health Services Act following the passage of Prop 1 in March of 2024. BHSA continues to be funded through that 1% tax on personal income over $1 million a year. And the goal of the BHSA is to modernize how California funds and delivers behavioral health care. It shifts the focus to treating behavioral health as specialty care while moving that broad public health prevention efforts to primary care, providers, and managed care plans. This transition aims to create a more integrated, coordinated system that meets people where they are and provides care that is timely and culturally responsive. Next slide. The BHSA reallocates funding from what was 5 components under the Mental Health Services Act now into 3 components under the Behavioral Health Services Act. That includes a 30% allocation for housing interventions, 35% to full service partnerships, and the last 35% to behavioral health services and supports. And we're going to discuss these in the next several slides. Next slide. So guiding principles of the legislation shape the goals of the law. And there has been a philosophical shift that's focused on maximizing funding efficiency, reducing homelessness and getting people off the street, and increasing accountability over the funds. And so I won't read the whole slide to you, but I think the biggest and strongest takeaway is that they're switching our public behavioral health, BHSA, funding as last resort so that providers are expected to be Medi-Cal certified, focus on Medi-Cal population that meets specialty mental health level of care before we access any of those BHSA funds. Next slide. BHSA wants to make sure that we target people who have Medi-Cal, who normally qualify for Medi-Cal, or who are indigent, which is generally the community members who have the fewest resources. Eligibility for BHSA, as I said, is with specialty mental care criteria for kids 25 years old and younger, as well as adults 26 and older. And BHSA also requires that counties prioritize these services for the populations you see listed here on this slide, which is the chronically homeless, those at risk of being in the justice system, those re-entering the community from prison, jail, or youth correctional facilities, those at risk of conservatorship or in the child welfare system, and those at risk of institutionalization. Next slide. There are 2 reporting documents in the BHSA, the Integrated Plan, or the IP, and the Behavioral Health Outcomes Accountability and Transparency Report, or what we lovingly call the BODR. The MHSA plan required 1 planning document and 1 accounting document, and both of these were due every year. But BHSA requires the planning documents, or that IP, is completed only once every 3 years. And then the accounting and evaluation document, that BODR, is what is due every year. The integrated plan is to primarily report on BHSA funded programs and some additional programs that are specifically identified in the legislation. And the BODR is a report on all department funding and programs, regardless of the funding source. This includes BHSA funds, general county funds, grants, realignment dollars, and any other place money comes from. Like MHSA, the BHSA integrated plan requires a community stakeholder planning process. Stakeholders are more readily defined in the new BHSA legislation and directs the county to work in a more integrated fashion with other larger organizations like the Public Health Department. BHSA requires county behavioral health to collaborate with public health on their community health assessment, or CHA, and their community health improvement plan, the CHIP. These are large community health assessments and intervention plan that were always required of public health, but BHSA now mandates that behavioral health becomes part of the governance and planning and implementation of that. and the plan will now align with the BHSA planning cycles and take place every 3 years. Timeliness in meeting deadlines and adhering to these regulatory requirements are also essential, and if not met, under new BHSA regulation, can result in the state issuing monetary sanctions to the county. Next slide. The authors of the MHSA established a regulatory required community stakeholder process that included MHSA education, a designated 30-day comment period on the annual draft plan, and a public hearing conducted by the Behavioral Health Commission. This was an annual process that coincided with the annual plan requirements. And now with BHSA, they have retained much of this concept, but it has aligned with the integrated plan process of once every 3 years. BHSA has expanded the list of required stakeholders, as you see a few of them listed here, and the collaboration with public health and managed care plans are part of this expanded engagement. The state expects to see meaningful engagement with BHSA target priority populations and those that serve them. That includes education about what BHSA is, as well as the plan services, which is why it's important. I'm going over with you today all the different elements and layers involved with this regulation. The Department of Healthcare Services is focused on building bridges between public health, managed care plans, and the behavioral health delivery system, with the ultimate goal of increasing cross-system collaboration and sharing funding. Next slide. Beginning on July 1st, 2026, prior to the state distributing local funds to counties each month, 10% of the total annual revenue will be allocated to state level initiatives. Previously under MHSA, it was 5%, so they've increased it to 10%. And this slide shows a breakdown of what that 10% covers. You'll notice that BHSA reallocates prevention funding as a state-directed activity. Prevention has been removed from local planning and implementation. Next slide. So that leads to the question, what does this mean for Riverside County? Counties are prohibited from using early intervention funds for stigma reduction programs that are aligned with population-based prevention activities. Population prevention programs may no longer be funded with local BHSA funds starting in July 2026. The most significant change is that prevention funds will be administered by the California Department of Public Health, or CDPH. At this time, it's unknown how CDPH will manage these funds. Programs that no longer meet BHSA criteria in Riverside County will sunset on June 30th, 2026. These programs include stigma reduction, mental health awareness, parenting, family, and other support programs focused on non-specialty mental health or non-Medi-Cal community members. BHSA also does not allow counties to spend funds on coalition activities. And here in Riverside County, we have a suicide prevention coalition that's been up and running for about 5 years. So we no longer can use these funds to support those efforts. However, the department does remain committed to suicide prevention, and we are working closely with our partners in public health to continue to seek other funding opportunities to maintain some of these activities. Next slide. After state-directed funding, the remaining 90% is allocated to counties and is required to be spent according to the component breakdown here. And I'm going to go through each of these in the next slides. So next slide. Housing interventions is 30% of the allocation. A housing intervention is housing assistance and supportive services that help people with a diagnosis achieve housing stability. Eligible individuals must be living with a serious mental illness or a substance use disorder and experiencing homelessness or at risk of becoming homeless. Funds are to be used to provide subsidies related to housing and providing supports to maintain housing. Rental subsidies, housing support such as deposits, supplies needed for home, pest control, things like this. And these funds cannot be used to provide mental health or substance use treatment services. The providers must connect individuals to those resources, but this portion of the funding cannot be used that way. We also cannot use any of the housing intervention funds for benefits that can be paid for through managed care plans. They are responsible for that. Currently in Riverside County, we do have all levels of housing intervention have been expanded, and we continue to build our Mead Valley Wellness Village. And BHSA will support this wellness village by helping us add 90 adult residential facility beds and 299 transitional living apartment units. Riverside has had a pretty robust housing development under the MHSA and with different grant opportunities. And as part of Prop 1, that proposition contained from last March also had a bond measure that's known as BCHIP. And Riverside successfully applied and was awarded funds through that bond. And one of the projects as a result of that will be a new county psychiatric hospital with expanded bed size and a better ability to treat children, which will be located next to the medical center in Moreno Valley. And then a second project will be for a children's and youth residential campus next to Harmony Haven in Beaumont. Next slide. 35% of the BHSA funds must be directed toward full service partnership programs, and programs must include substance use disorder or co-occurring treatment services. BHSA requires every county to implement 2 levels of care for adults and older adults under full service partnership. The highest level of FSP care is an evidence-based practice called ACT, or Assertive Community Treatment, or FACT, which is the Forensic Assertive Community Treatment model. And then the other level of FSP care is intensive case management, or ICM. And this is the first level of care beyond standard outpatient care, and it's designed to be the less intensive FSP level. FSPs are also required to include individual placement and support, or IPS, which is a vocational rehabilitation model of supported employment for people with serious mental illness. And pursuant to BHSA, we must implement these FSP and IPS programs beginning July 2026. For children, the only FSP that's been identified at this time is high fidelity wraparound. The state continues to explore other options, so there may be changes as they continue to adjust and modify the policy manual. BHSA also requires counties to offer low barrier access to medications for addiction treatment, or MAT, and prioritize those who are at risk of overdose, experiencing homelessness, or justice involvement. RUHS Behavioral Health utilizes navigation teams to connect individuals to MAT services via the Emergency Department Bridge Program. And the Psychiatric Residency Program works alongside the HOPE program to provide MAT to homeless individuals in the community. Next slide. Counties are required to allocate the final 35% of their total allocation to the behavioral health services and supports component, which includes our children's, adult, and older adult systems of care, outreach and engagement, workforce education and training, capital facilities and technology, early intervention programs, and innovative behavioral health pilots and projects. One thing to note about the outreach and engagement, this is very different than what we're used to under MHSA. These funds are really focused on activities intended to reach, identify, and engage individuals, families, and communities in the behavioral health system and to reduce access and disparities to care. The focus is about engagement and linkage for Medi-Cal recipients who need specialty mental health level of services. Next slide. 51% of that BHSS component must be spent on early intervention services. And of that, 51% must be spent on youth aged 25 and younger. BHSA changes the old MHSA definition of early intervention. Under BHSA, early intervention is the proactive approach of identifying and addressing behavioral health concerns at their earliest stages before they escalate into more severe, disabling, or chronic conditions, and to reduce disparities in behavioral health. This can include crisis systems of care. County early intervention programs target BHSA priority populations and have the goal of identifying these individuals for access and linkage to treatment. BHSA also mandates that counties fund first episode psychosis, or FEP programs, which is an evidence-based model geared toward transition age youth who've had their first psychotic break. Behavioral health already operates this program countywide, so that's great because we're already in alignment with that requirement. Next slide. So having said all of that about BHSS, what does it mean for our county? In Riverside County, we really don't expect a reduction in terms of the services that are available in our outpatient system of care, which is fabulous. With BHSA and another initiative called BH Connect, we actually are going to be adding to our service array some of the required evidence-based practices that the state has included. And this includes functional family therapy and multisystemic therapy, as well as expanding our parent-child interaction therapy services. Those are all children's models. We also anticipate our workforce education and training programs to remain in place. And then we have 9 programs that are currently funded under our MHSA Prevention and Early Intervention Plan that meet regulatory requirement for early intervention under BHSA. So those programs will continue to be funded, and you can see the list right there on the slide. All early intervention service providers must meet new BHSA regulations, though, and this includes obtaining Medi-Cal certification. Some of our contractors doing these programs, well, they've all said they want to do it, but we need to make sure that they complete that certification process. So we are providing technical assistance and support and everything we can to make sure that they can successfully make that transition. Next slide. So this is an overview of our timeline that we're on. So we are currently in the stakeholder process, and our draft plan is due to the state by March 31st with a final Board of Supervisor approved plan due June 30th, 2026. Next slide. I'm going to share a QR code with you in just a moment, but there are 2 formal opportunities for community to express their opinions on the plan. The first is a 30-day public posting of the draft plan that'll occur sometime in the first quarter of the calendar year. We're aiming sometime in January. And when the plan will be posted on the department's website, feedback can be provided electronically. And then the next opportunity is going to be to provide written or verbal feedback at a public hearing that's conducted by our Behavioral Health Commission. And we're aiming for that to be sometime in February. We're still working on locking in dates, and we'll let you know when that is. We plan to have 3 regional events in the evening, so we'll let you know when those happen, when those get scheduled. To coincide with those in-person public hearings, there will be a virtual public hearing. So we've been doing this the last few years. We will have public hearing videos in English, ASL, and Spanish that will be posted 24/7 on our website for a minimum of 3 weeks, if not longer. And feedback can be provided electronically or by calling the dedicated voicemail hotline if you prefer to speak it. You see that on the slide. And then next slide. In the meantime, you can provide feedback now. So you can scan this QR code, or when you get the slides, you can click that link to be able, it'll connect you to a survey to get some basic information from you, your thoughts about where we are and any gaps that you may see in the mental health system at this time. And so please take a moment to do that. We do value your feedback, and that will be included in our plan to the state. And that's what I have for you. So thank you so much for the opportunity to share. Are there any questions or comments at this time?
So Diana, maybe we can get some more feedback from the community. This is a much broader system that funds a lot of different things that are outside the scope of the continuum of care, because you're helping many different populations. This is really, MHSA, and now the new, say it again, what it's called?
BHSA, Behavioral Health Services Act.
Does so many wonderful things that RUHS oversees. I think what would be helpful for the nonprofits and the rest of the stakeholders here, and Tanya, you can chime in too, is are there any new, as a result of this, could there be any new opportunities for them to receive funding for housing related activities or activities that would support those that are homeless? So that would be one question I think that would be helpful to everybody listening to you. And then also, I know Larissa and Marcus and team, are involved in many different housing type programs. So, if the continuum of care needs to rally around them and give feedback to support recommendations for what they do, because I'm assuming they'll get some support from these funds for that, correct?
Yeah,
Like
so Marcus
HOPE?
is leading the charge on that section, really. I'm here to help and be back up with our compliance and regulatory requirements. So in terms of, so you said a lot of things right there, and it has
Yeah.
other thoughts for me to share. So
Yeah.
in terms of the housing, I think we're pretty fully allocated, but I will defer to Marcus if he wants to add anything, or Larissa, feel free to speak around any future funding opportunities specific to housing. I don't know if either of you want to add anything.
Sure, I can jump in. Thanks, Diana. For the upcoming year in this next iteration of the plan, yes, we're fully allocated. But to Diana's point, her role is to help coordinate this larger BHSA effort across our whole department and whole county. each of us within our UHS behavioral health that represents a different division, whether it's adults or children's or housing or crisis. Our job is to be the hands and the feet, so to speak, and that in the regions and with the stakeholders that we interact with, to both help share what the department's doing and then also to bring back feedback from those groups of stakeholders back to Diana for her as sort of a central point to collect that feedback and for us to analyze it and see what needs the community is experiencing and see if there's ways that the BHSA plan can help.
Do you have suggestions, Marcus, so that we can be helpful? Because there's a lot of information, right? So if the folks want to be supportive, especially I know regarding, homeless, the area of housing supports, and I know you have to be careful because you're staff, but we're asking for your help if you have suggestions for how we can be helpful giving feedback to the plan. It's so that I think that would be helpful because there's a lot of information in there. So because we want to support the good work that you all do, and I'm sure others will have questions and comments, but that's certainly my question. My question is how we can be helpful because we can make suggestions all the day long, but we need to do it within the parameters of the requirements and what the funds can support, right?
Yeah, and I can speak to that a little bit. I think the survey is pretty structured, so it will help guide some of the feedback that we're looking for. And
Okay.
then there are lots of other opportunities I want to make mention that we have several different kind of advisory boards and culturally specific subcommittees that meet regularly throughout the year. And these are spaces where folks may want to get involved to talk all year long about supports, whether they're specific to housing or other kinds of community supports for individuals, and is a space to give feedback for this. So that's all part of our system. And as feedback rolls in, it rolls all the way up. So if it's housing, it's going to make its way to Marcus and to me for the plan. If it's about our children's services, it's going to make its way to our children's deputy so that they can talk, look at how that feedback impacts our service delivery system. And so after this, Zuli will send you a bunch of materials that will include all of those advisory boards and opportunities to give feedback throughout the year, as well as a little bit more information about where you can find the full draft plan. It's not ready yet. When it's ready, it's going to post in January. And so for those of you that if you are interested in getting a little bit more into the weeds and specifics around the parameters of the funding, it will be in there and the specifics of what we are funding the year coming. And then you can come to the public hearing as well and give that feedback at that time.
Okay, and one last thing, because I know there are other questions. Can you help people to understand what you mean by funding of last resort? If you look at the populations that we serve, most would qualify for Medi-Cal. So can you give examples
Sure.
of what funding of last resort means?
So it just means if they have another source of funding to support what we're doing, that funding needs to be accessed first. Largely for those that you serve, they're going to meet specialty mental health access criteria or be indigent. And that's who we serve as a department. And so that shouldn't be much of a problem. This is more like, especially in the services I oversee right now, prevention and early intervention, we've been doing more broad community engagement where we might be working with someone who's not meeting specialty level of care. We're no longer allowed to serve them. That needs to be done through managed care plans. Or if we're engaging with anybody with private health insurance, commercial insurance, we're no longer allowed to serve them. That commercial provider needs to either reimburse us to do the service or they need to provide the service directly. So that really is kind of that long-term, larger vision that the state has for behavioral health transformation, is that all the players need to play their part. And for a long time, managed care plans and commercial plans have really taken a step back from that prevention and mild support, leaving, and either it was undone or for the past 15 to 20 years, the county's been covering it. And now they're saying, no, everybody has a part and your members need the same full spectrum of services that ours do. So they really want everyone stepping up into their space in this spectrum of care. And that's really what we mean by funding of last resort. So if they are meeting specialty mental health level of care, they are on Medi-Cal or indigent, those are our peeps, and that's who BHSA is meant to serve.
Okay, did we lose Neha? You had your hand up. I hope you will come back on and ask the question. I know she had her hand up.
Thank you. I was just about to put in the chat that I have to log off and that I'll reach out to Diana separately. Hi, Diana. Part of the school aging subcommittee for suicide prevention. And shout out to Amy Primrose as well. She's been wonderful support and resource for us. So my role at Riverside County Office of Education is one of my roles is to support the McKinney-Vento / homeless youth within our county. And I provide technical assistance to our district liaisons that support the homeless children and youth. The biggest barrier that I'm coming across consistently year after year from them is the housing need for our children and youth, especially that are not TAY age group. And so students that are younger than 14, families that need the housing. And there just aren't enough beds available, shelters available, apartments, and you name it. The housing need for younger families, younger children and their families is huge. And I'm just wondering how we can maybe see if there's a way to tap into BHSA or Medi-Cal, or I don't know. I'm just trying to be innovative or plant a seed and just say that that's a huge barrier among the younger children.
Yeah, agreed. Something we hear often. I'm gonna tap in Marcus though, if you have any you want to share about that.
I think I would just agree with the need, and the McKinney-Vento numbers, right, are always really staggering, for lack of a better word that comes to mind. So I think, to Neha, back to the question that Karen asked, the feedback, one directly responding to the survey that Diana has provided is really helpful. And the only other thing I would add is, as you all know, our managed care plan partners have expanded the types of housing and rental assistance that they can offer in the last couple of years through CalAIM, through community supports. But that's really been on the back of a federal waiver. The federal government, right, has indicated that they don't plan to renew those types of waivers. And so I think that's a place that we can use everybody's help, is with advocacy, to say BHSA is one limited pot of funds. The amount is not greater than it was in the past. And in fact, we have to give an additional admin percentage to the state, more so than we did in past years. So we're not making do with more, we're making do with less.
Yes.
So that federal advocacy to say BHSA is an important tool in the toolkit is not the only tool in the toolkit, and we need federal support that our nonprofit organizations, our managed care plans, others can do the work that they do and can expand that work.
Well said. Ms. Tanya?
I just wanted to thank Diana for coming on and joining us to share this information. If you attended our last multidisciplinary webinar where we talked about suicide prevention and safety planning, then you received really good information that came from Diana's team, which she leads. And I just wanted to share as a form of feedback that I think part of what our team at the Office of Homeless Services hears when we're out in the community and networking with our different partners, many who are on this call, is that one, they're very appreciative of, I think, our intentionality in really integrating. And I think when you compare other counties across the nation, it's really rare that you have a county behavioral health department that has like a direct homeless response team. So I think that's really, really important to recognize, but also too, where you have behavioral health serving as your lead for coordinated entry system. And so I think that provides a lot of opportunity. And so now going back to the feedback we get from partners is, how do we do a better job at everything, but making sure that we're matching people up to the right level of care. So if someone calls the hotline, or if an outreach team has somebody in front of them who needs behavioral health treatment, mental health services, and could benefit from a not maybe something higher than permanent supportive housing, that we are aware that there's an awareness of how the referral process to that type of service or facility works, and that we can, that we're better facilitating those matches. So all that said, I will say I just left a meeting in the Southwest region where the overall response was, hey, we feel that the connection between county behavioral health services has dramatically improved. So I think that's huge. But I think if we could just, look at how we do better matching, and so our boots on the ground know how to access those services, I think we'd be a win. But I know, again, some of that challenge is just resource availability and really even understanding whether those beds or resources are available.
Yeah, I mean, great points and great comments. And I think, also making sure that boots on the ground know of the systems that are in place. And I think, meetings like this one, as well as maybe others that community groups gather in, is just a great space to remind folks of what those processes are. And I will defer to my colleagues, Larissa, Marcus, if you wanted to highlight what those, where people can find the easiest and best access to link folks when they need access. I will let you do that.
And Diana, for access, you're talking about access to housing or access to give feedback? Sorry.
Oh, I think Tanya was referring to just making sure that it's clear with all partners when they encounter someone with a mental health issue that needs housing. I think, Tanya, if I understood you correctly, how they get them linked up to our system.
And
Yeah,
I think
no,
I
go
was
ahead,
gonna
please.
add, I think I understand, part of that is a work in progress, right? It's gonna be something that we kind of develop. And so ideally, right, I think everyone envisions you call one place for someone who's homeless, and if they need behavioral health, if they need permanent supportive housing, or if they need behavioral health supportive housing, that they're screened for that all in one place versus having to call a different hotline number. So I just sharing, I realize that some of this may be a vision for the future, so I just wanted to pass it on.
Chris says yes, what Tanya says. Well, I think the other thing too is different subregions are a little bit different. I mean, I'll just give a shout out to behavioral health. We can't say enough about mobile crisis management team and the CBAT support. We have a clinic in the city. The integration is really close. So, but I recognize that this is a big, huge county, right? And resources are limited, and they do, they serve the whole subregion. That's not just one city, but it's so nice, when you have those relationships and can make those connections. So, but Home Connect could be the easiest way, Tanya. What do you think? Yes? Or
selfishly, I'm gonna say yes, because everybody here has that number.
Yeah.
But again, I agree, and I want to echo that. And we're very fortunate in Riverside County to have the relationship we have with behavioral health. When I shared with other counties that behavioral health serves as our coordinated entry system lead, they're just blown away, and they're like, okay, how do we mirror that? Because it makes a lot of sense. And I know in today's agenda and maybe following this presentation, behavioral health is going to speak on a new effort that they're leading, which I don't think any other county department could have done. So there's a lot of benefits, pros and cons, and but at the same time, we are a region that sets high goals, and so it would be really cool if we had one number where you could just call and get everything. So yeah.
Well, Diana, unless there's any other questions, I'll just say this. This work is complicated. These funding streams come with massive amounts of regulations, and you guys have to navigate a very difficult system and integrate that with other funding resources. There's so much. I don't think people have any idea, how complicated it is behind the scenes, and you guys make it look easy. And, we get to collaborate with all of you, and, the system appreciates you guys so much. So we want to send the love your way and hope that we can be as helpful as possible. And I think what you're asking is the more people that complete the survey is how we can be helpful to you.
Absolutely, yes. And thank you so much for the time today and the great feedback. And then Zuli will send out all of our additional information that can give you a lot more spaces to engage with our system and find out about the other services that we have as well. So thanks so much.
Thank you. Okay, don't forget to take the survey, everybody. Your voice matters. Make a difference. Okay, agenda item 6.2, Prop 47 Local Advisory Committee update. Rashana, gonna turn it over to you and team.
Thank you, Madam Chair. Good afternoon, everyone, and thank you again for being with us the last portion of your day today. My name is Rashana Walker with Housing and Workforce Solutions, Office of Homeless Services, and I oversee all of our state and federal funding that are administered through the continuum of care. And I'll pause right there just for a little bit to allow Margarita to introduce herself, and then we'll go into the presentation.
Hi, my name is Margarita McKissick. I am the program manager over Prop 47, working under Rashana and Catherine at the Office of Homeless Services.
Thank you, Margarita. And next slide, please. So Proposition 47 is not new to the continuum of care, but I'll go over a brief overview. Prop 47 was a voter-approved initiative on the November 2014 ballot that reduced felonies to misdemeanors for specified low-level drug and property crimes. So each year, the state savings generated by this implementation are deposited into the Safe Neighborhoods and Schools Fund, the Schools Fund. 65% of these savings are set aside annually for the BSCC to administer a competitive grant program. And last year around this time, our county submitted an application for cohort 4 to the state California Board and state and community corrections to support individuals in our region, and we received $8 million to support eligible individuals out in Riverside County. The purpose of Prop 47 is to address the root causes of the justice system involvement through treatment, support services, and community-based interventions. Eligibility requirements, so the eligible population are those who are justice impacted. They also have to have a substance use disorder and or a severe mental illness. The intent of this program is to provide coordinated participant-centered services to include mental health and or substance use disorder treatments, as well as diversion programs for those who are justice impacted. This program again is funded by BSCC, and we are in our cohort, the 4th cohort of the fund distribution. And later in the presentation, you'll understand why we chose the program model we are utilizing. Next slide, Zuli. As part of this program, we are required to maintain a local advisory committee throughout the grant duration. And in that committee must include local stakeholders with experience and or expertise in the services that will be implemented throughout the program. The function of the LAC, which is a local advisory committee, is to identify and prioritize the most pressing needs that needs to be addressed for the target population. Also identify strategies, programs, and our services to be undertaken to address those needs, the development of the project, as well as ongoing implementation of this project. Also too, when we presented this to the COC, it was suggested that we include our minimum of quarterly LAC meetings with the COC meetings. So moving forward, you will see us present this quarterly within our COC meetings. So next slide, please. We would like to highlight the stakeholders from each of these organizations represented on our current committee, and I would like to thank them because they have been instrumental in the delivery of services thus far for this program. So currently on our board, we have starting representatives from Starting Over Inc., our Housing and Workforce Development Division, RUHS Behavior Health, Healthcare in Action, Lighthouse Social Service Centers, and Salvation Army. And I put a plug in there. Please reach out to the CLC@rivco.org if you would like to be part of this Proposition 47 Local Advisory Committee meeting. Now I want to pass it over to Margarita, who will be providing more information about the service provider who they are doing all of the hard work in the community. And just to note, this is just an extension of what the work they've already done through our HIP funding. So take it away, Margarita.
Thank you, Rashana. Yes, Healthcare in Action is our Prop 47 subrecipient. We launched our RIVCO Project Street Recovery on May 1st of this year, also called Street Medicine. The Healthcare in Action is a nonprofit medical group and case management organization with an exclusive focus on serving unhoused communities throughout the innovative street medicine model. Their approach involves delivering care directly in the streets and in encampments via mobile medical vans. They have deployed 5 multidisciplinary teams with 7 staff members. And I'm just going to go briefly into those staff members just to give you an idea of what they do. The primary care lead physician provides clinical leadership and oversight for the team. The physician assistant, nurse, practitioner, or the medical provider, either or, they will provide the medical, provide the medical care for the patients. The clinical support partner supports the clinical team in providing healthcare services and administrative supportive services. The care management supervisor provides comprehensive care plans. The peer navigator is someone with lived experiences and/or specialized training. The coordinator will be responsible for managing incoming patients and documentation. And then we have the behavioral health specialist responsible for the mental health needs of our patients. All strategically support the mobile medicine, the psychiatric care, the substance care, substance use disorder treatments, the management care services, and the housing navigation. You can go to the next screen, Zuli. Thank you. This brings me back to the root that Rashana mentioned earlier, addressing the root cause of justice system involvement through treatment, support services, and community-based interventions. We continue the work with street medicine under the Prop 47 grant because of its proven success in addressing root causes and improving the health outcomes. This reported data shows that of the 1,122 individuals served, 63 received treatment for SMI, severe mental illness. 43% received SUD treatment. This measurement impacts and demonstrates why our team remained committed to carry out this work forward into the Prop 47. Tackling the root issues that foster safe neighborhoods, recovery, and reintegration. You can go to the next slide. Thanks, Judy. One of our goals is to identify and secure stable housing and income for recovering individuals. Key benefits: reduce recidivism, support successful reentry, address the root causes, improve public safety and community health, cost savings for the state. We are currently moving into a year-long strategic service model. Next slide, please. This approach is slow and steady, recognizing that all will not arrive at the same time, but they will get there. It is a 12-month plan. The first part of that plan, we're expecting the first month to be intake assessment. Once it moves on, like to intermediate services and the educational job, there's 2 months set aside for that, another 2 months set aside for that. So depending on where you are and where we meet you determines how quickly you move along in this 12-month plan. Next slide, please. Thank you, Zuli. To support this effort, after launching, we kicked off a mixer, the Resources Restore Lives mixer. It was a great event that was held at the Ruston. This was a way to connect the low desert, the high desert, the resources, all of the recovery facilities that were out there that we wanted to tap into, get them together so that they could connect with HIA, which is our subrecipient, ask questions, showcase their mission, their impact, their services, and it was really good. I plan to schedule, I want to say at least 2 more because this is a 3-year grant just to keep the connection going, the communication going. I also created a resource guide out of that. And yes, a resource guide that is sent to all of the people that participated in the mixer. You can go to the next slide, Zuli. Thank you. Now we want to bring Eddie Manacho, who is a general manager and medical director for the Inland Empire. He is going to talk about some updates for the Prop 47 and give a success story.
Yeah, thank you so much, Margarita, and for Roshana as well for all the support that you've given us. The HIP was just a step in the right direction. And, I've been doing street medicine since 2017. And I think one of the best things to do in street medicine is to acknowledge where systems work and where systems don't work. And I think, where Riverside County has believed in us and other counties as well really means a lot to us because there's a lot of street medicine teams that come and go, unfortunately. And we're happy to be able to help, push this Prop 47 forward and serve. And Rashawn, I think, or Margaret, am I allowed to share my screen? That way I could share my PowerPoint. I know I couldn't get you the slides. I didn't put that many slides together. One thing I think that, can you guys see my slides?
Yeah.
Yes.
Okay, cool. One thing that we didn't mention in the explanation of like our services and what we do have addiction medicine fellows. We have addiction medicine specialists and docs that treat substance use as a specialty. And so it goes hand in hand with what we're trying to do here. And then we also utilize psychiatrists that come from RUHS. So we are big fans of RUHS and what they do for the community. And I would be remiss not to mention Dana Gutierrez here that discussed the roots of well, I was tying it to what Margarita was saying in terms of the roots of what causes this issue. And before I go into this, I just want to mention this because I think it's really important. I was at a street medicine conference once, and there was a person from not in my backyard that was at the conference saying that we didn't want this type of service in our area, and he was asking what the answer was to solve homelessness. And one of my mentors from Boston, when I was doing my fellowship over there, had said we just need to treat our kids better. And I think to Diana Gutierrez's programs that she had out there for the kids to address the trauma-informed care for the kids is really pivotal. And then, what we're doing now in terms of Prop 47 is very reactive, but I think it's needed as well. So what we do at HIA, we do combine street medicine with managed care, so Calium services, and we do this through, the big MCPs like IHP and Molina, but anybody that treats the homeless knows that, IHP takes up about 95% of them. So they're our biggest players. But these are just some of the numbers that you could see that we've treated in the last few months. Now, these numbers don't do a true justification of what we do. We have a team in Hemet, San Jacinto, a team that covers all of South County from Temecula all the way up to Lake Elsinore. We have 2 teams in Riverside, and then a subcontracting team in the desert. But these numbers we've treated. This is the number that we've treated up to date. How many we've diagnosed with severe mental illness? 60, and most of the folks that we diagnose with severe mental illness are being treated. As you saw on the previous slide, we treat about 65% of them. Some of that mental service could be whether that's a medication, whether it's counseling. what have you. Substance use diagnosis, same thing. I mean, we're diagnosing a good handful of the patients that we have enrolled in our program. I would say one caveat to these numbers is the HMIS access. Everyone knows HMIS access is sometimes a bottleneck to our ability to expand, which thankfully to Roshana and Margarita are working with us to be able to expand that to properly address and put the patients that we're truly serving in this region. But I love that 12-month plan that Margarita had added, and it goes hand in hand with the story that we have today. And for I know they only gave me 2 minutes, but I like to talk. So I'm gonna just go to this success story so we can go here really quick. So I changed the person's name. This was a person that we found in the river bottom in the beginning of the year. We enrolled him in Prop 47, and one of our peer navigators, to Margarita's point, is that when I first started doing street medicine in Boston, a lot of them, the folks that we used that were like essentially the backbone of the program, were leading us into the streets. And Daniel Belke is one of our peer navigators, our star peer navigators in Riverside, had lived experience and has been sober for 10 years himself, had interacted with one of these individuals that was justice impacted, had substance use disorder, and is actively being treated for mental illness as we speak, and was telling him about going into a detox center. And shortly after, and one thing that he was really keen on, I think one of the things that we do in motivational interviewing is trying to find what motivates these patients to get them going. And for him, it was his daughter, and his substance use was getting in the way of that. And a lot of times that's the case for them in their family issues. But in May 27th, he actually agreed to go to detox. He completed a full 90-day treatment at MFI, which we're making these connections now as we speak to be able to streamline this. And then after the 90 days, he went into the sober living. So August 27th, within a month ago. And now he's actually working as a construction worker. And whether now it's our job to prevent that from, receding back to where he was, and making sure that he stays sober, and that he's connected to the things that motivate him, which is his daughter. And so this is just one of many stories, but we plan on, broadening our HMIS access, and then also working with the navigation center to make sure that we have we're doing wraparound services for those that are on probation. And as we're just getting started, this is a three-year contract. We will continue to have these stories and streamline this as we can. So thank you, Margarita, for all your help, and Roshana, same thing. You guys have been nothing but supportive. So I appreciate you guys in all the work you guys are doing in the background.
There's a question in the chat from Carol Alba, how other smaller nonprofits can enroll people in Prop 47. I'm not sure which on the team wants to take that.
So
Yeah.
I'll share Eddie's presentation, because he does have a contact slide. So I'll share that right now in the chat. And I think Tanya had a comment or a question.
Yeah, truly just a comment. I love that success story, and it makes me think about the many people that your team and other teams have helped get into treatment that are successfully connected to housing, so that right after treatment they can just get keys and move into a permanent housing situation and not return to homelessness. But there's also the other side of as the reality of our housing shortage remains a problem, that also means that a lot of people are finishing treatment and not having permanent destinations to go to. So I think that as a COC, we should have, maybe that's a discussion for another future, next meeting or two, on do other COCs prioritize individuals who have completed treatment into the next housing bed that comes available through or as part of their coordinated entry process? I don't know, but I think it's something to worth looking into, because these individuals have made a commitment, they've done their part, and it just it just hurts. I don't know what else to say, to know that sometimes they're having to return back to the streets. So no solution right now, but I think we need to have a conversation on prioritization.
Is that tied to, what Marcus is going to be talking about in some way, shape, or form?
Definitely connected. So yeah.
Because it's going to be I don't know
that we solve for that issue, but it's connected. Yeah.
Okay. I'm with you, Tanya. I think that's a great idea.
That is an amazing idea.
Because
priority.
It's an incentive.
It's
that allows
absolutely.
choice.
Absolutely.
I love it. I think we should figure something out. But okay, we still have a lot to cover, so I'm going to move us on to the next agenda item. Thank you, team. Standing items. Miss Emma, do you have some updates for us?
Yes, I do. Zulie, can you advance the slide? Thank you. Good afternoon, COC members, Madam Chair, and partner agencies. It is a pleasure to be here with all of you to provide this COC lead update. My name is Emma Perez Singh, and I am the manager here at the Office of Homeless Services. First update, on September 8th, our COC resubmitted the COC build application, which was originally released back in 2024 to provide funding for permanent supportive housing development within a COC's region. We included 2 permanent supportive housing projects that the COC approved, totaling $8.1 million. These 2 projects, located in Moreno Valley and Menifee, would increase the number of permanent supportive housing in our region by 106. Previous rounds of this funding were canceled, and we learned last week that the National Alliance to End Homelessness filed a request for a restraining order against HUD in the most recent application, which was successfully granted. So the challenge we now face is that this funding expires on September 30th, and it remains uncertain how the situation will ultimately be resolved. But nevertheless, we went ahead and resubmitted our application, as I stated, on September 8th. So additionally, the COC Builds NOFO requirements sparked a lot of concern among COC and advocates because of the new and controversial requirements that were introduced, such as immigration enforcement provisions, SONRA compliance, which is which is a sexual, oh my gosh, I forget it's Sex Offender Notification and Registration Act, and restrictions on harm reduction practices and limitations on housing first models. So again, submitted our application. We are awaiting news. The National Alliance to End Homelessness is an advocacy group that is involved in supporting continuums of care and homeless work across the nation. And so we wait to hear what happens. I'll pause there for any additional comments or questions. All right. So I will move on. We have submitted the COC HAP 6 application. That was done on August the 28th. So yay for that. I want to give a special thank you to Amy Primrose Puente, Mireya Orozco, Roshana Walker, and Brandon Trahan for their hard work and dedication in ensuring that the application was completed and submitted on time. I also want to recognize and thank the City of Riverside, Michelle Davis and her team for their partnership, coordination, and support in working alongside the COC and the county throughout this process. They were an essential and critical partner, and we would not have been able to submit our application without their coordination and support. As many of you know, HAP has been a critical funding source that has supported numerous programs within our system of care. And this critical funding source, this application represents another important step in sustaining and strengthening those efforts. Moving on to upcoming funding opportunities that we have on our radar. The 2025 COC NOFO, we are expecting any day now. Again, looking at COC builds and some of those requirements makes us a little nervous about what's going to come in that COC NOFO. We are preparing nonetheless, business as usual from prior years, just so that we are ahead of the ball and prepared should the NOFO look like previous years. We are ready to go, but we will keep the COC abreast of any changes, anything that happens related to these funding opportunities. As soon as we know, we will let you know. Also, encampment resolution funds at the last meeting, I mentioned that those are going to be coming out for cities and counties, end of 2025, early 2026. So just have that there as a placeholder reminder for everyone. Also, wanted to make sure everyone was aware that the Youth Homelessness Demonstration Program, or YHDP, Permanent Supportive Housing RFP, Request for Proposal, it is being worked on, and we expect to release that in November or December, and that will go out through our normal channels, COC email blast, and that was not me. I'm sorry. The
Sure, it
COC
wasn't
email.
you.
Are you going to give us it was the dog, Emma?
That was not me. Okay. The COC email blast, we'll post it on our website and it'll go out through public purchase. And also the YHDP subrecipient mixer, that is invitation only for our YHDP subrecipients, and that will also be going out through our normal notification channels. All right, that's it. Thank you, everybody.
Are we able to like capture COC bloopers that we can do like a? Hey, you know what? Everyone can use a little laugh. That was awesome. Okay.
Any questions or comments?
I've never seen Emma's face turn so red. Okay, we have a lot to cover. I'm going to move us on to the next agenda item, okay? Functional zero on veteran homelessness. As I understand it, we're going to continue to keep this as a standing agenda item because we do want to reach functional zero. So, Jen, you're up.
Good afternoon. This is the shortest I'll ever speak in my time here. So next slide. So at a glance, as of yesterday, we had 22 members on the CES community queue. And from the internal by name list, 4 of the members are document ready for selection for either rapid rehousing or permanent supportive housing. And 2 of those have pending rapid rehousing or permanent supportive housing referrals. And next and last slide. As a reminder, the Home Connect email is homeconnect@ruhealth.org. And then for any member seeking services, that's the front no wrong door policy, that 1-800 number for the Home Connect hotline for any members seeking services. And that's it, as promised. Very, very short presentation. Thank you, everyone.
Comments or questions from the group? Okay, hearing none, we're going to move on to the next agenda item. Thank you. Okay, dun, 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 dun. Something we've been so excited to hear about. I remember when we kind of talked about this, I want to say, what year were we in Washington, D.C. at the National Alliance to End Homelessness Conference, and the concept of restructuring VI SPDAT. And I know that behavioral health has been working really hard on this in collaboration with Housing and Workforce Solutions. We're super excited to hear. It looks like it's called HAST. So, Marcus, we are super excited to hear about this. Take it away.
Well, I'm going to ask Monique to lead us, and I'll be here to back her up if she needs any help or if there's any questions for me. But yeah, to summarize, we are really excited, and it's been a long time in coming, and I think it's going to be a big benefit to our COC as a whole. So Monique, I'll let you lead us.
Oh, sorry about that, Monique.
No
like
worries.
always
Thank
excited
you,
to have
Madam
you,
Chair.
girl. Take it away.
Hello, friends. My name is Monique Rodriguez Torres, the Administrative Services Manager for our Coordinated Entry System. And today I'll share some updates on our new assessment tool in development. As stated, Marcus Cannon is also on the line and he will share some additional details. Please feel free to ask any questions during or after this presentation because we would love all of your feedback. So we wanted to provide you an update about the implementation of the VI Spit-Out replacement tool that we previously discussed in other meetings. As a reminder, this new tool, the HAST, it stands for Housing Assistance Screening Tool. It is a predictive, evidence-based, and trauma-informed triage tool. It's designed to help us better identify the highest risk unhoused residents in Riverside County. The tool is designed to estimate the risk of death or serious harms while someone is living unsheltered. It uses a combination of things, self-reported lived experiences from within the past 6 months, HMIS data, and in future phases, it's going to link county data such as emergency room visits, hospitalizations, jail bookings, behavioral health hospitalizations, coroner data, things of that nature. This tool is different from the VI Spit-Out in that it is data-driven and validated rather than just relying on intuition-based survey questions. It's trauma-informed by reducing intrusive questions in an effort to respect the dignity of the people that we serve. We are working in collaboration with HWS and the Center for Social Data Analytics, or CSDA, to develop and validate this tool, ensuring that it is rooted in research and best practices. And so I will pause for any questions. And then I have more slides.
I don't want to take away, but I think Tanya alluded to, this is pretty rare. We're like way ahead of a lot of other counties, right?
Yes, I don't know if I was supposed to echo that or if behavioral health was going to come in and say yes.
I heard the question to Tanya, so I was waiting. It was a test to see if she was paying attention, had her mic unmuted. I agree with Tanya. I think there's very few counties nationwide that have been able to do something like this. So,
yay. Next slide, please. All right, so the user interface for the HAST tool is being built directly into HMIS so that frontline staff can access it and use it where they already perform client assessments. And here's how the tool works. A history score is generated automatically each day using HMIS data. During intake or at triage, a custom assessment score is also added in real time. This will be linked to the county data for validation purposes. Together, these form a final HAST score, giving the staff and CES immediate feedback of risk levels. This integration into Clarity is intentional. It reduces duplication, it makes the tool user-friendly, and also ensures that staff can use it without needing any new platforms. Next slide, please. Thank you. Currently, we're in the testing phase. We're focusing on validating the HAST tool inside HMIS with homeless services data. Our next steps are linking additional county data sets, such as the coroner's data, hospitalizations, and arrest, things I spoke about on previous slides. Training our frontline staff on how to use this tool effectively, and importantly, training all of you, all of us, training the entire COC to ensure consistent understanding and adoption across our system. Long-term, this tool will undergo ongoing testing to ensure fairness, accuracy, trauma-informed use. We are working closely with our partners at the CSDA to make sure this tool remains both effective and equitable over time. And I will pause for any questions.
Well, I'm sure we're gonna have a lot of questions from everybody, but just to kind of set the stage, providers are used to VI Spit-Out and working with their clients to answer questions about their current situation. And depending upon how they answer their questions impacts the scores. And I think some of the long-term conversations that have been had around VI Spit-Out is sometimes clients are afraid to tell the truth, so they score low. Other clients that are desperate for resources might answer differently because they're desperate to access resources, knowing maybe perhaps a higher score might be able to help them access certain types of services. And the process has evolved. So I know you guys have worked hard to allow case managers to update it and give feedback, because sometimes clients might be afraid to tell the truth, or maybe their mental illness might impact how they answer the questions, right? So this is a transition to be data driven, but is it going to be 100% data driven, or will it be a combination where clients and their answers will also impact the scores? Because I could see where not everybody will show up in data systems. So I'm going to play devil's advocate and throw that out there for you and hear what you have to say.
Yeah, for sure. So I will say that this is the tool also is not the end all be all. We do use our data validation to as part of the tool, but I also want to make sure that I'm very clear that we're not eliminating the option of special prioritization, and that this tool should not interrupt any resources that are dedicated to subpopulations. So there absolutely will still be some type of an assessment if we truly believe that this assessment score is not reflective of somebody's true vulnerabilities. There will be other ways, there will be the other prioritization process that we will be able to adhere to. Marcus, I don't know if you wanted to add anything to that.
Only if there's follow-up questions. I think that's a good answer.
Okay.
I think just to highlight what Monique said, we welcome feedback and we welcome it now. I know we've also been working on, and I hope we'll send out soon, a brief CES satisfaction survey. What are we doing well? What could we do better? And in there, we want to include the opportunity to provide comment about this as well. We know not everybody can attend these meetings, and so want to make sure that there's as much opportunity as possible for people to make comments on the process. I think the big theme is that this helps us have to ask clients fewer questions, which is trauma informed, and then to use available data so that the answers that we get to client questions are truly informative of risk. To your point, Karen, right? Each of us, as we answer those questions, may have different motivations or different understandings of the questions, but if we can look at the different data sets that are available to figure out who's most vulnerable, then we can use that to prioritize resources. I wish we weren't having this conversation at all. I wish we were in an environment where we had PSH for everyone. But and that's, I think, the hard part when you're the provider on the street and you're serving 100 people. It's like all these people need housing.
Yeah.
We don't disagree. But yet at the same time, we're charged with working with the limited resources that we have and operating coordinated entry. So I think this will help us do a better job of reducing bias, reducing potentially trauma, exacerbating questions, and making sure we're truly targeting those most in need.
Just a question, is there any thought to, you may have already gone through this process, so forgive me, any focus groups or feedback from the populations that we're serving in terms of VI SPDAT versus the new tool and how that?
I think that's a good suggestion. As I think and probably a lot of people on this call know, many communities sort of around the country have moved away from the VI SPDAT.
Yeah.
So I don't really expect any heartache to move. And even the creator of the VI SPDAT, right, has moved away from the VI SPDAT. So I don't expect heartache in moving away, but I think it's a great idea as we roll out the new tool to check in with our consumers directly and say, hey, this was the tool that we used when we got you into housing. What was helpful? What was not helpful? And continually seek that feedback. I think Monique highlighted this in her presentation, but part of this methodology as well is to do an annual reassessment or testing and make sure that the questions that we're asking are still accurately predicting risk. And so, Monique, maybe that would be a good time as well to do our focus group with consumers to ask them about their experience.
Yeah, absolutely agreed.
So what is our timeline?
So, Marcus, do you want to take that? I know we're in the testing phase still for HMIS, and then the next testing phase is through our other county data.
Agreed. I don't know the number of days. I mean, I certainly think we're much, much closer. Karen, with your permission and Madam Chair, with your permission, I think by our next COC meeting, maybe we'll have a better indication of a number of days that we could put on it.
Well, I didn't even know we were that close, so I'm just throwing it out there. And I don't know if anybody else has any questions. I don't want to dominate the conversation. We just want to be supportive. I ask questions, just to ask to looking at the big picture, but we know you've spent an instrumental amount of time, and this has to be that you're working towards a very good product. So we just want to be supportive in any way that we can. And obviously, we're all going to be involved in it once you roll it out. So does anybody else have any comments or questions as you think about how you walk your clients through completion of VI SPDAT and kind of the structure that Monique has presented to you as the instrument will be evolving? Do you have any questions? Because you guys are doing the work. You have to, you're working with the clients. Do you have any questions? Okay. Well, I hope when you guys get it done at some point, when that SoCal consortium of the CSEs gets together, Tanya, that you can raise the roof and brag about Riverside County and bring behavioral health with you, okay?
That's my favorite thing to do. Count on me. Thank you, behavioral health.
Yeah, absolutely.
Thank you all.
We're grateful to the whole COC team and county team, but also all the nonprofits, and rolling this out will be a joint effort. Monique talked about training. That'll be COC wide, and we're certainly hopeful for our success is your success. And then if we are successful, then Tanya can go brag about us and give us if not a 10 out of 10, give us at least an 8 out of 10 and go tell people about the good work.
Yeah. It truly does take a village, and I feel like we have the best village. So
thank you guys. We appreciate you. We look forward to the next update as it is feasible for you. Don't feel pressure. We know you want to do it right. So, okay. Next agenda. Oh, here we are. Good. Maybe we can end on time. Woohoo! So these are informational items that you can find on the committee reports in the Google Drive. No letters of support. Boo! Come on, you guys. Send them in so we can sign them. And then there are some annual performance reports in there if you'd like to review them. Next slide, please. Anybody have any requests for future agenda items? We always love to hear if you have suggestions, say it now. Okay, well, if you don't have anything now, just remember csc@rivco.org. You can email it anytime. Next slide, please. Announcements. Okay, you guys, let's see. We still have 85 people. Of the 85 that are out there, do you have any announcements that you want to share with the rest of us? Okay. Next slide.
Chair, I would actually like to do one announcement. I just would like to plug our Recovery Happens event that's coming up. So Recovery Happens is going to be on September the 25th from 11:30 until 4:30 p.m. at Fairmount Park. So please join us and celebrate those who are in recovery, and bring your members that are wanting to start that journey.
Nice. Thank you. Anybody else? Okay. Next slide. Okay, everybody, look at that. 5 minutes to spare. Use your 5 minutes wisely to do something amazing to help another person. And please remember this work, you do it from your heart and soul. Please take time to care for yourself, self-care, because when you care for yourself, then you can do a good job caring for others. And I'm the pot calling the kettle. So we all get lost in this work, but you guys are all so amazing. So I just want you to know, on behalf of the whole Continuum of Care team, we love you. We appreciate you. Have a beautiful rest of your day.
Take it easy, family. Have a nice day.
Bye, everyone.